still a few trickling. There's still a few people trickling in. Good evening. My name is Bella Lapp, and I am a student project manager at the Clark Forum for Contemporary Issues. Before we begin, I would like to take a moment to acknowledge that Dickinson College is on the unceded lands of the Susquehannock Nation. We hereby recognize the prior status and enduring diversity of this land and the many indigenous nations that stand in relation to it, particularly the thousands of indigenous children from dozens of tribes forced into the reprogramming camp established at the Carlisle Indian Industrial School starting in 1879. Dickinson College supported this agenda of cultural eradication in both word and deed. Turning honestly toward that shameful past animates this acknowledgement and gives orientation to our desire for a reconciled future. Accordingly, this living land acknowledgement is intentionally incomplete, a reflection of the ongoing process it represents, to learn respectfully from the stories of this land and the people that carry them, to think reflectively about the injustice of our shared past, and act responsibly with that knowledge today to inspire a more equitable tomorrow. On behalf of the Clark Forum, the Bechtel Leadership Fund, and the Department of International Studies, I would like to welcome you to tonight's Bechtel Lecture, No Do Gap, a Fallacy for Scale-Up and Sustainability. The Bechtel Lectureship was established in honor of Emeriti faculty Joan Bechtel, retired librarian at the Widner-Spar Dickinson College Library, who served from 1971 to 1995, and her late husband, Professor Dan Bechtel, who was a member of Dickinson's Department of Religion from 1964 to 1995, to support the hosting of speakers and events regarding Africa on campus. We are honored to have Joan Bechtel in the audience tonight, as well as her daughter Lisa, her son Tim, and her daughter-in-law Felicia. I am an anthropology major, and there's a huge emphasis on ethical research and informed consent within the field of anthropology, especially applied anthropology. This semester, I'm taking a class called Research Methods in Global Health with Professor Basantes, and as I prepare to conduct my own research, I must obviously consider its purpose. What will my data be used for? Can it be used to help people? And if so, what channels of authority do I have to navigate in order to justify its effectiveness and implement change? I must be aware of the no-do gap, as all researchers do, While reading Dr. Sarker's published work, I was most interested in her study on maternal health care seeking behavior in adolescent girls in Bangladesh. I believe studies on care-seeking behavior are hugely important to global health because they can define the social and environmental factors that either prevent or encourage medical care. Without these kinds of studies, healthcare interventions would be far less informed and far less effective. Dr. Malabika Sarker is currently a professor of the practice of behavioral and social sciences at Brown School of Public Health at Brown University. Dr. Sarker has taught health in 4 different continents and is an expert in implementation research in Sub-Saharan Africa and Bangladesh. In 2018, Dr. Sarker received the Global Heroines of Health Award. She is the International Advisory Member for the World Federation Public Health Association, the National Institute of Health Research UK, and the Lancet Global Health. Dr. Sarker also founded the Institute Review Board and the Center of Excellence of Science of Implementation and Scale Up at the BRAC James P. Grant School of Public Health in Bangladesh. On the back of this evening's program, you will find a QR code. We would appreciate if you complete the survey and provide feedback on how you find out about Clark Forum events. There will be a question and answer session immediately following the program, so please hold all questions until that time. The Clark Forum welcomes differences of opinions expressed politely, succinctly, and thoughtfully. Disruptive behavior or harassment of the speaker, members of the Dickinson community, or audience members will not be tolerated. As a show of respect for our speaker and everyone in attendance, please stay until the end of the program, including the question and answer session. Please note that in the event of an emergency, accessible exits can be found through the double doors behind you and down the right hallway. The emergency exit will then be to your left. At this time, I ask that you silence all cell phones and electronic devices. And now please welcome Dr. Malabika Sarker.
Thank you very much, Bella, for your very kind introduction. I would like to thank Clark Forum for inviting me. It's a really, I would say, the delightful experience. I have been in many universities, but I never felt so much care and hospitality from any other institute, globally. So thank you, Clark Forum, especially to Laura, Sarah, and others for organizing. Just one disclaimer. I'm a severe asthma patient. So what happened after COVID, when I'm in a kind of crowded room, because maybe the lack of oxygen or the fresh air, I start coughing. So just that I'm not a COVID positive or I'm not suffering from flu, just to make sure. So today's lecture is about, based on my experience, the research I have done in Bangladesh. I'm a physician in background, but then I did my graduate studies in epidemiology, and for a long time I was busy doing the epidemiological study, and my focus was HIV and Sub-Saharan Africa. I did my PhD on prevention of mother-to-child transmission of HIV in Burkina Faso and later in Uganda and Tanzania, and went back to Bangladesh after 6 years of teaching in University of Heidelberg in Germany. And then I started working on tuberculosis, dengue, malaria, infectious disease, but at the same time maternal child health and sexual reproductive health. And I felt that something is missing because what I'm doing, the epidemiological survey, I'm publishing, I became the professor, then associate dean, but it's not for the population. Believe me, 90% of the paper that we publish as globally is not helpful for the community because they don't translate into the policy or action. That's the brutal reality. We have our promotion, we get our grant, we travel all over the world, we do the research, but in reality, that to improve the population health outcome, those are not very helpful. One of the major reasons is that your policymakers don't wait there to read your Lancet paper or New England Journal Medicine papers. So the communication between researcher and the policymaker, there's a gap, and there's the no-do gap. I'll talk about that we know the solution. We researchers do a lot of efficacy trial, effectiveness trial, but they don't translate it into the action. So with that, because I work in global health, we know that I think that what COVID has done to this world, that every time I travel, previously the immigration officer, because I'm from Bangladesh and I hold a Bangladeshi passport, what do you do in public health? What is public health? But after COVID, every single immigration officer anywhere in the country, when I say the public health, they say COVID. So the COVID brought the awareness, because before that, if you think about the HIV, it was limited to Sub-Saharan Africa. The infectious disease is the low-income country. The high-income country has the non-communicable disease, but the general population don't have the awareness. There's something called public health, which is for prevention and the promotion, not focusing on only the clinical aspect of the health. So these are the, if you look at the global, at the threat currently, due to this rapid and uneven pace globalization, there's inequity everywhere. We know about the pandemic, antimicrobial resistance, non-communicable disease, definitely the fragile setting, the humanitarian setting, the crisis, air pollution, and climate change. All of us know about the effect of climate change, the heat, the flood, the rain, that is, everything is changing, those of us who are skeptical. But these global health challenges also becoming very complex because of the diverse context. There is an interplay between illness and the environment and inequity. So that diverse context, because whenever we have an intervention, even if you think about the COVID, the one of the kind of an common practice of the policymakers that prescribing that intervention and implement, not thinking about the context. So you can, the picture on the top is the Rohingya refugee in Bangladesh. There are 1 million refugees, and you can see that 1 million people live in one hilly area. So the per square meter population density is like 1,000. And then you have the urbanization, then you have the rural. So the intervention, what we offer, we need to think about the context and the target population. We cannot offer the same service or same intervention. If you think about, the COVID vaccination program, we will not offer it the same way in Harlem, in New York, or Alabama. Because of the population yield implementation strategy, the delivery strategy, the communication will be very different. You cannot communicate with 80 plus years old population and then 20 years, because that's very, very important. There's just a lot of interplay that the climate change is huge. I don't know how much you're aware that the heat is, like a lot of cities are now the heat island, and it has been shown that it has a direct effect on the diabetes and acute kidney disease. So there are a lot of non-communicable disease and infectious disease that many countries did not. Germany, I lived in Germany for 10 years. I go there every year to teach. Last time I was there, they say that along the Rhine Valley, there's malaria. They never had malaria. But because of the heat, the temperature, the tropical weather, so and we carry, that we carry all the bugs and insects in our suitcase. So we go somewhere and spread the disease. And definitely the pandemic, the health system is weak. US and UK proved that. USA, if you look at the way they deal with COVID compared to many small countries like Bangladesh or Vietnam, New Zealand definitely has done very well. But those countries did very well, dealing with the COVID. So, but many high-income countries struggling with the weak health system. There's poor healthcare financing. USA, we know that 50 to 60 million people don't have any access to health insurance. So the healthcare financing, where the privatization is very different than many countries where it's the government paid. There's inequity. When you talk about the inequity, we'll talk about the gender, the geographic context, but there are different kind of inequity. There's the lack of opportunity. In Bangladesh, the child marriage is highly prevalent. By 18, that 51% of the girls get married. The young men, they don't have any access to the sexual reproductive health care or education because the society in South Asia very much sexual education limited to the married, not the unmarried one. So the whole delivery mechanism is only for the married couple, not the young unmarried. But there's also positive side. I think in the 21st century, there are a lot of opportunities for global health equity. There are creative solutions. We expanded the research methodology, the new methodology, emerging methodology. There are a lot of meaningful collaboration, north-south, south-north, north-north. There are creative solutions that I have worked on developing artificial intelligence for diagnosing diabetic retinopathy, the painting the roof for reducing the temperature, the finger image for vaccination. So you can track the children so that they can not be falter from the immunization camp or vaccination camp. Our research methodology, particularly I do a lot of mixed method, and qualitative research has been there. Very, very interesting method, like deliberative method that we have done, deliberative interview. There are like a visual diaries or shadowing. And we know the quantitative always has its place in public health. The partnership, I spoke about the partnership, that a lot of research have been done, and even the implementation, like an intervention, efficacy or effectiveness trial through the South-South and North-North partnership. So let's discuss about what is no-do gap. So no-do gap, it says that we know the solution, but we don't do. And so more and more in the world, there is a lot of focus on evidence-based intervention. I don't know whether you are aware, 60 to 70% intervention or the service that you do, except the drug trial, these are not evidence-based. It has been maybe implemented in one country, and then another policymaker felt that it's important, and they started implementing. But if you look at the data, there was a systematic review that 126 papers, they found that only 14% evidence-based research outcomes in real-world settings. So that this failure of research to act upon or to translate into the policy is the no-do gap. We know solution, but we don't do that. But when I was in my career for last 23 years as a researcher and 10 years as an implementer, 33 years I'm in the public health, that I observed, and through my research, I realized that it's not a dichotomous linear knowing-do gap. It's a continuum, and that's what I will showcase you through different examples that how it is continuum. Sometimes we don't know the solution. So there's unknown solution. An example is that eye illness prevalence in the low-income country is highly prevalent. A lot of even simple like reading glass. I did a study in the urban slum, and I found it really fascinating that that's just very important to know the culture, context, and the population. So you will never see poor people, those who wear glass, if you travel in Africa or Asia or Latin America. And in the urban slum, when we were doing the study, and said that, why don't you wear the eyeglasses, and they sort of, like some of them, they said, oh, wearing glasses is the elite and educated people do that. So there's a stigma associated with the eyeglass. So one rickshaw puller told me, I had a problem and I bought the eyeglass, and everybody started telling me, oh, you became professor now. You are wearing eyeglasses. So very simple thing. The second is for women, they don't read. If you look at the cataract prevalence, the most women in the low-income countries become blind because they are not diagnosed. So until you sew, you don't know that you can't see. But for men, they can read. So many women end up going to the healthcare facility at the end of the cataract when it's not treatable anymore. But there's no community-based intervention on the eye illness. We talk about the NCD, non-communicable disease, but there's also infection. There's a lot of comorbidity. And we think of the comorbidity, we think, okay, diabetes and hypertension, cardiovascular disease and COPD, chronic obstructive airway disease. But there's a lot of infection, the tuberculosis and the diabetes. And if you look at Bangladesh, there's altogether almost 1 in 3 person suffer from kind of a diabetes, but there's no solution. The second is chronic kidney disease. In India, the chronic kidney disease prevalence is 10% of the population suffer from chronic kidney disease. In Bangladesh, there are 30 million people. And the chronic kidney disease, it's very clinical. So the dialysis, but there's not much the preventive care. Sometimes we know, but we don't do. So about the heat, the way heat wave is in, even in the USA, I already mentioned that it causes a lot of diseases. And there's a simple solution, the painting the roof. The series of studies have been done. Recently, the Stanford group also came up that if you paint your roof, even with white paint, it reduces the temperature. I did a randomized controlled trial study in Bangladesh in the urban slum, because the urban slum heat is very high because it's the corrugated tin. And in the slum, it's thousands of people, in Dhaka. Bangladesh is the size of Wisconsin. It hosts 170 million people. And then you have a Dhaka, 22 million people. And we painted heat, and we found the temperature dropped significantly in midday. But even then, you will not see any kind of initiative to paint that. And we spoke to the policymaker, they paint the school roof, paint the garments industry, the roof, but there's not much initiative except China, that there are some initiative in China. Sometimes we know, but we don't scale up. So the maternal death, if you look at the social determinants of health, the maternal death is one of the most common public health problem. And I do think that the maternal health indicates that how do we treat women. Because if a health system can treat women, pregnant women, with respect and can give the service, they can actually give the same thing to the man too. So the Deborah Main she said that so there are 3 delays of maternal death. First delay is the decision making. Most often the woman is not the decision maker, it's the husband or mother-in-law. The second delay is the transport, that sometimes they have bleeding, the women, eclampsia, seizure, but can't go to the hospital because the road is not paved or there's no transport. So offering a simple transport service can save thousands or millions of women's lives. And we did a study with the Rohingya refugee women with UNFP, United Nations Family Planning Association, and we just provided a microbus. And the utilization of the healthcare has been increased significantly, and the many women saved because they were in the health facility on time. Sometimes we know we do soon. One is that healthcare expenditure. In Bangladesh, per capita healthcare expenditure is $54. USA pays the highest amount of healthcare expenditure in the world. It's $12,000 per person. But if you look at the health outcome of the USA, ranking is number 33. So countries like Cuba, Vietnam is far ahead. Forget about the Scandinavian countries or the European countries. So what happened, that there's out-of-pocket expenditure. People pay from their own pocket. So there's an organization, they thought that, okay, we should give them, I think many of you know about microfinance. We received the Nobel Prize, Dr. Yunus, because of the microfinance that you give small credit money to the women for their livelihood. So they came up with the idea that they will give you the loan if somebody has a catastrophic health condition in the like in a household. There's an injury, there's a heart attack, the women need cesarean section. But they did it, they gave the loan, but the coverage was very low. And we're surprised. They're giving the money, but people are not taking the money. And then we looked at the design, and we found that first of all, there's no marketing. People didn't understand that, they can take the money. But the problem was the whole process. They have to go to the doctor assigned by that NGO, get the prescription, and go to the office, take the money. So later, we changed the whole medical treatment loan, and you can see the utilization and taking the loan has been increased from 2.2% to 7.7%. And this is a picture of that how we take the women to the health facility when with a labor pain in a rural village. Sometimes we do, but do it badly. So kangaroo mother care, neonatal death, the preterm birth is very common in low-income country, and one of the major reasons of the newborn death. So the kangaroo mother care is a very kind of cost-effective, simple, feasible intervention that mother will hold the baby on her chest, and there are a series of randomized control trial has shown that it has increased the survival rate of this newborn. And that Bangladesh government, they expanded that kangaroo mother care, and we did a study in several health facilities, and we found that it's not working. But because of the quality of the care is so poor, the health worker even don't kind of clarify that the mother how to hold it. And it's summer, so mother can't hold it for longer time. And sometimes mother doesn't know that how long they have to hold it. So there are a lot of good intervention, but they are not very successful because of the poor quality. Sometimes we know and do complacently. So one of the most successful program in the world is called Direct Observed Treatment Short Course for TB, tuberculosis, where you give the treatment through the community health worker. They give the drug, and then it's a 6 months treatment. And the cure rate is 90%. The coverage is excellent. The South Asia, African countries did very well. But then it's the pulmonary tuberculosis. So when we looked at data, we found that extrapulmonary TB, you can have TB in the gland, in the brain, in the bones. The 15% of all TB cases have extrapulmonary TB. But you can see that we looked at the pathway of the patients, the extrapulmonary TB. Those TB patients don't go to that dot center. They go to the drug seller. They go to the traditional healer. They go to other doctors because the program is so much focused on the cough that the health worker even don't mention that you can have TB without cough. So the only focus is the primary symptom, cough and fever, and most of the pulmonary TB patients then later suffer. So what is the summary lesson that we found? That there are interventions not developed yet. There are interventions not tested but implemented. The intervention not implemented as intended. Intervention not scaled up to impact health program. And intervention not sustained for a useful period. And that comes that the last 15 years, this new field emerged, that implementation science, because we found that the world suffer from pilotitis. There are a lot of pilot intervention, which doesn't scale up. Because when you do a pilot testing, it's mostly researchers do. It is very controlled environment. But then when you take the program to a routine hospital or healthcare service, it's really, they don't implement the way it's supposed to implement. So that's the story of the implementation science. And that implementation science has like a two component. One is implementation research. So we look at the feasibility of that implementation, the intervention, not intervention, all intervention people accept. If you think of the COVID vaccination, in Bangladesh, the COVID vaccination rate among 12 plus population is 90%. And think about the USA or many countries. So implementation research look at those bottlenecks, that is it problem with the service delivery, or how do you design the program so that your community can accept that. The second component is knowledge translation. How do you communicate with the policymakers? They will not, again, that read your papers with odds ratio or that published. So we need to come up with how to communicate with them through doing the video, infograph, policy brief, through dissemination workshop. So this is the definition of the implementation science, that the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practice into routine practice and hints to improve the quality and the effectiveness of health services. So what is the aspiration for the future global health? If you want to make an intervention successful, whether the COVID pandemic or non-communicable disease or air pollution, disease related to the air pollution or the climate change, we need to marry two kind of in discipline. The implementation science needs to marry with the big data and the machine learning, because only the big data can show you that what's happening, and not the researcher going and looking at the small data. The routine data from a hospital or from a health facility or any community-based organization, it gives the real picture what's happening. Because researcher, when we do the study, there are a lot of biasness. We collect the data, we have the methodology, but it all gets lost when it's kind of offered by the routine health worker, because they do have a lot of overburdened or many hours of work. So only that way we can tackle global health threat and reduce inequity and improve our health outcomes. So we need to focus on the implementation strategy. How can it's called delivery science or science of delivery. How do you deliver any intervention? Any intervention, it can be education, it can be health, so that the population that you are aiming for, they accept it, they can access it, it is available to that, and it is affordable to that. Only that way you can improve the health outcome of the population level. Thank you very much. I don't know whether I was very fast, but I wanted to have more question answer.
Oh, that's okay.
That session.
That's
yeah.
Okay. We can have lots of time for questions. Okay. All right. Thank you, Dr. Sarker, for that. At this time, we will start our question and answer session. Because this program is being recorded, we ask that you raise your hand and wait for a microphone to reach you before you ask your question. We reserve the first question for students, and then we will open it up to the rest of the audience. So at this point, we're looking for our first question.
So I know you talked about working with a lot of non-government organizations. Mm-hmm. How does that work versus working directly with a country's government? What are the relationships between non-government organizations and researchers? How?
It depends on country. So if you look at the Sub-Saharan Africa, that all health program is dominated by the public, the government. Very little role for NGOs. There's some of the international NGOs work, the development partners, but it's with the government. But when you go to Bangladesh or Pakistan, there are many, many small NGOs who worked in relation with the government. So working with the NGO, that, NGO is like a private entity. So the decision making is quick. If there's a solution, they can implement immediately. But the government is a lot of bureaucracy. And to be fair with, it's not of the bureaucracy, because Minister of Health cannot decide about the money until Minister of Finance agrees to that, or the budget is allocated. Or some of the health is not an independent problem anymore in this world. You can have an excellent hospital, but the road is not paved. But Ministry of Health does not build the road. You have to go to other ministry. So with the government, it's really kind of a longer process. So what more and more the research we are doing, the researcher, that we try to engage government from the very beginning of the research. Because you cannot do the research at the end and have a fantastic dissemination workshop in a fancy hotel and bring Ministry of Health and say that. They will not. They will come and they will listen and they will leave. So how to engage them from the buy-in, that from the very beginning. But it's much easier when I did the research for NGOs, because you can feed the research funding very quickly to the NGO leaders than compared to the government. Yeah.
So I was, from what I was getting from this is it sounds like it's often very hard to get different organizations to change the way that they do business, essentially. Mm-hmm. And oftentimes they come and they hear what you have to say, and then nothing changes. Is there any ways that you have found a lot more success in specifically a little bit further? I don't know if you have any experience in the Middle East, more anywhere from the Gulf to Jordan or Syria. With that, it's a very specific, and of course, like you said, every region has its own context. Have you found, like, for instance, I know the Germans, they do a lot of investment projects in health in a country like Jordan and Syria, but oftentimes I see in the same way that you refer to, things don't really change.
Yeah, it depends on which health program you are talking about. If it is sexual reproductive health, then Middle East has a very different view towards that. But if it is like, maternal health or non-communicable disease, that most of the governments have a good policy, but we have to remember, a lot of policy government agrees to, it's in kind of making happy the donors and international players. So sometimes you see the policy, but it doesn't translate it into the guideline or implementation. It stays at the policy level. So for example, if you look at I'm bringing the most controversial topic in the world, the abortion policy. If you look at even the Saudi Arab or Bahrain, abortion is legal to save women's life, or if there's incest or there's a rape. But is there a program there? No health worker is trained for conducting the abortion. So so depending on the topic, so the climate change in Bangladesh is doing a lot of climate change, but nothing on climate change and health. The government has their own mindset, what is their priority. At the same time, it is also kind of how should I say that, lot of aid and the international relationship with not only the WHO, but the different donors that, USAID does not give, I don't know how many of you know about the global gag rule, global gag policy. So the global gag policy is in Mexico City policy, 1983. The senior Bush, 1985, I think senior Bush started that USAID will not give any money for abortion. Fine. That's a good, because they don't believe in abortion. But the thing is that the policy stated it's not only I will not give you the money for abortion, but as a government or as an NGO, if you receive money from UK to do the abortion, you can't do that. That's bullying. Because I can say that it's my money, don't do that. But they're saying that and the BRAC, that one of the Bangladeshi organization, USAID withdrew $300 million aid, which was for maternal health and the family planning. So think about logically that USAID policy is actually creating more abortion. Because if you withdraw money from the family planning program and the maternal health program, so all these donors, because most of the low-income countries receive a lot of money from different donors, all of these donors have their different agenda, and the government have their own agenda. They also have their, people, so the citizen, they have their own agenda. So it's a very delicate balance that what to prioritize and what not to. So NCD, most countries accept non-communicable disease. Nobody minds because our, the priest or the political leaders can have a heart attack, so they don't mind. So the most problem is with the women's health. So most of the countries struggle when it comes to the women's health, when it comes to the LGBTQ right. So these are the sensitive issues, that very difficult. So many government sign the policy, but many cases it does not implement. Because signing the policy to make the others happy, yeah. I think you have a question, yes.
Thank you for your talk. I'd be interested to hear about whether you know of places, contexts, specific health issues in which this no-do gap is being effectively addressed, where research is being translated into some effective implementations. Have you observed that in places where, and if you have, what is going on in those places which has allowed some success, more success than what you've described as sort of the norm pretty much globally?
Yes, so
where is this working well? Who's doing it well?
So it's many countries are doing well. So one of the examples I'll give that the COVID. So what happened when COVID started, in Bangladesh, we started distributing the mask, but people, they don't want to use the mask because, so we did a preliminary research. We found that most of the kind of community members, they don't want to use the mask. And then we sat with we shared the result with the government and also the NGOs. And we thought that how can we promote the mask? And then we realized that if we engage the community leaders, because the community leaders, I'm not talking about the government representative, it's the imam in the mosque, it's the school teacher, it's the, the health worker in the community. And we engaged them, the community engagement, and we started distributing the mask through them, and then it significantly increased. So depending on the context, I think it's very important to know what are the bottlenecks. The context is, or if you think about, I worked in Burkina Faso, and their prevention of child transmission of HIV, and we found that if we offer the HIV testing with the pregnancy care, it's much easier to non-stigmatize the women because they come for antenatal care, and we can offer the HIV testing. So in the beginning, HIV testing was opt-in, so that every woman we used to ask that, do you want to do the HIV testing? And they said, no. Because they don't think that they are at risk. They said, we are the good women. Why should I go for HIV testing? But then we made it, the government and others, particularly Sub-Saharan Africa, they made it opt-out. So they just say that, I'll do the HIV testing. They don't ask proactively, and the HIV testing has been increased, and then they can be enrolled in antiretroviral therapy. But it's very important. I think there is a tension between researcher and the implementer. We researchers have a sense of arrogance. I think we know it all. We are the researcher. And sometimes this type of research needs very active engagement of the policymakers and the implementer. Only my health worker, in the Rhode Island, the primary healthcare center can tell me what are the problems that can be offering that service. So I do believe, and more is happening globally because implementation science is now, the reason I was recruited at Brown, because I'm an implementation researcher. They don't have any implementation researcher. So more and more we try to work with the implementers, the community, the policymakers, that and the research should not be done in an ivory tower. I think that's why it's very important to analyze the routine data and to train even implementer to look at the data and identify the bottleneck, who are coming for service, who are not, who are dropping out from my like, NCD care or HIV care. So this is the way there are a lot of works happening in the world, but it's not on a mass scale that what we wanted to have it, yeah. Yes.
Okay, hi. Thank you for coming. I was just wondering, with non-communicable diseases, how would you, or like, what's a kind of different approach to, like, getting people to be more educated about non-communicable diseases within communities, because it's not as prevalent or not like visual, but you can have it, but they just don't know what necessarily it is.
Yeah, so unfortunately, non-communicable disease still now dominate. I'm a clinician, I'm a physician by training, but non-communicable disease is very much dominated by clinicians, very much drug specific. So I wrote 2 proposals for NIH UK and it got rejected. My idea was to use the children at home as a change agent. So one of the reasons for hypertension is that high salt intake. So if you go to the South Asia or Africa, the salt intake is 5, 6, 7, 8 times more. Or like, the food habit, lot of carbohydrate, going for a walk. So I had the research project that we will train the adolescent of the family, and then they will, because I've seen that my brother was a chain smoker. But when his youngest son tell that, if you smoke, I will not talk to you. And he quit. And my sister-in-law was very upset that I am telling that for 15 years and he doesn't listen to me. So for non-communicable disease, this behavior change is very difficult. And we have to be very innovative that how can we kind of encourage the people to change the behavior, particularly the food habit. We did a study on the app use of the university students, and we found, and then we did a survey on the mental health, the depression, and we found that the young people who kind of order more on the food, the app, that's a strong indicator of depression and anxiety, because they continuously order. So use of that app, we thought it is Facebook, but it's not the Facebook. So the 2 things came up. One is hopping on different apps, that they are on Facebook, then Instagram, then Snapchat, then food. And the second was using the food app. So it's very important to know for us that it's not the one size fits all. Because always we have the generation gap with the previous generation, but now I think it's a really staggering gap. You generation, you language, the way I think it's difficult for us to understand. So it will be very important to engage you to come up with a solution. And we don't do that. All the interventions set up in the capital by the senior researcher, the CDC, WHO, all these old people, 40, 50 plus people, they sit there and they come up with the solution for different diseases and illness. So the more we can engage our those who are respondent or those who are patient, I think in developing the solution, the more useful it will be. Especially the non-communicable disease is killing. The average life expectancy of the USA has reduced to almost 10 to 15 years in the last 20 years. Bella? Emilia.
Hi, Malabika. Thank you for sharing all these experiences with us. And one of the things I was wondering regarding implementation science, in my experience, is that sometimes it's because reproducing what was successful in research relies on the health workers taking sometimes more responsibilities. So I was wondering if you could speak a little bit about your experience of, how to navigate that challenge of getting the intervention out there without asking already overburdened, people to take on more responsibilities. How have you navigated that challenge?
I think that's very important. What happened in the health system in the US or any countries, we give the donors, or the government or anybody gives money for software, not for hardware. What do I mean by software? We give money for health worker training. We give money for logistics. We give money for drugs. We don't increase the health workers' number. So 30 years back, there's not non-communicable disease or emerging infectious disease. But now you have the same health worker who is dealing with 20 different things. So that's where I find it the beauty of implementation research. So one of the efficacy trial was done by one of our like a pediatric researcher that, you cut the umbilical cord and the many children in Africa and Asia suffer from infection because they cut the umbilical cord with like a blade or with a scissor, which is not cleaned. So what happened that there was a lot of randomized control that if you put the chlorhexidine, we use the chlorhexidine, the blue kind of liquid, even during the COVID, you just have it, the cotton, and then clean it to the chlorhexidine, the infection, the sepsis of the neonate in the umbilical cord significantly reduced. It's very simple. So they did it trial with the researcher. They recruited the physician. They did that. And then they asked the health worker in the primary health care do that, the health worker. The problem was they introduced the program. Then you have to have the budget for chlorhexidine. You see, the problem is we have such a silo mindset. So everybody says like, okay, like, you do, but then you have to there's a budget for chlorhexidine, there's a budget for more cotton, and then they have to be replaced. So the chlorhexidine, they gave a huge bottle, and then after 2 months it finished, and they said, oh, there's no budget for that. So the problem was that when we don't think about sometimes that holistic, that if you want to introduce a new intervention, it's not only the new intervention, it needs also support, and it needs to the continuity of the support. So definitely, I do think that health workers are less paid in this world. The least paid health worker, I'm not talking about the physician or the surgeon. The primary health care, who are the backbone of a health system, are that they have $20, $30, $40, $50 salary. I don't know how much in the USA, but maybe not more than $1,000 a month or $1,500 a month. But we are overburdening them with a lot of intervention. So I agree with you, but then you have to invest. You have to cut down your defense, like a budget, and then have the healthcare budget. But I think the only country I came to know that my son goes and loves that country, the Costa Rica, they don't have a defense budget. Costa Rica, they don't have any defense system in the defense budget. But even in Bangladesh, who is going to attack Bangladesh? I'm sorry. It's a small country like a pancake with a lot of water. But you see that our defense budget is 3 times than our health budget. We have huge military. They have the subsidized food. They have the car. They sit in the capital, have a fancy house, and then my health worker with a $10 salary, the primary health care worker. So I was telling to the, recently, when it came to the health, it was all about the infectious disease and epidemiology and the disease. Then for last 30 years, we realized that social determinants is important, with the gender, socioeconomic, the context. Last 5 years, there are a lot of attention on commercial determinant. And we realized that the commercial determinant, whether the pharmaceutical company or Coke company or those corporate, has a huge influence on the health market, or your HMO, or the insurance company. So there's a very nice series of paper on Lancet, I think last year or year before, on this commercial determinants of health, that how the corporate rules the health of us in this world, yeah.
We have time for 2 more questions.
Bella. Yes, please, yeah, please.
If there are 2 others for other people.
I was very interested by your mention of South-South collaboration.
Mm-hmm.
And I'd like to hear a bit about your experience of that phenomenon, where you saw it first, you first encountered it, how it's grown, the ways in which it happens and is conducted, what benefits are being derived from it, the motivation for it. Just share some of your experience with sort of the transfer and exchange of knowledge and good practice.
Yeah, there are now a lot of, like, I have several projects with, the last project I have is on the community health worker with Malawi, Kenya, and Malawi, Kenya, which is the other third country, Zambia, the 3 countries. And we had the Bangladesh, India, and Indonesia, the Asian countries. So that one of the project was that how do we deliver, Asia is very much successful in delivering service to the community health worker. So these are the community health volunteer. In the community, our contraceptive user rate is 70% because it's the community health worker who delivered that service. So that was the reproductive healthcare message. So what we have done, that our colleagues from Africa, they came and they visited different program, and they then they tested a program that how can you use the community health worker. But there was an interesting problem there. The problem was that we started with the community health worker, and it was successful in Asia because Asian women mobility is not acceptable. So in Asia, the women stays at home. So even if I want to go outside there, like if I'm like an 18-year-old girl, and then I want to go out, my mother will say that, oh, take your 5-year-old brother, who will hold my hand, and he is like a man. And then, so the project that in Bangladesh and Asia, like India, they have done, taking that opportunity that being a community health worker, they will encourage them to go out in the community, and this mobility is an indicator of empowerment. And they were very happy that those women, we call them in India, they call them Asha. In Pakistan, they call lady doctor. In Bangladesh, they call Shastra Shevika or family welfare assistant. They're very happy, community recognition. First, when they wanted to do that, Africa, the women are very mobile. Mobility is not a problem in Africa, because if you go to any African country, Sub-Saharan Africa or African countries, women are in the market, they are selling. They are taking the motorcycle or bike. So first thing when they started the program, they said, how much we are going to be paid? So the idea was that in Bangladesh, it will be voluntary work, doing it for community, will give you the social recognition. You are the doctor of the community. And those, I would say that they did not buy it. The first thing was that how much salary you will give me for that. So then they realized that they have to have a paid worker, because without payment that the women don't work. So again, that even within the South, when the context change, your intervention needs to be changed. So that's one implementation science. It keeps telling that you do randomized control trial, good. But when you go to the real life intervention, you need to consider what is the health system, how is the health worker, how is the context and geographical context. So in terms, think about that, Germany after COVID, when I went to Heidelberg, if you are in the tram and if you don't wear mask, you have to pay €100. That's mandatory. You have to wear the mask. So, and then I came to USA. My sister that time was living in New Mexico, and I found that if you get the COVID vaccine, we'll give you $100. So I thought maybe I should go for another vaccine there. Depending on the context, how will you, but the German people will not say anything. They are, the Germans, they love to follow the rules and regulation, whatever rules that you ask them, which will not be applicable for the USA, like such a libertarian society that government will say that, oh, if you don't wear it, you have to pay €100. I don't think it will work. So the context is very, very important, and the population also. And we have to, intervention design, implementation strategy, delivery mechanism, we have to keep in that mind. That's how we are going to do that. Bella, you wanted to have the last question?
Time for one more question, yeah.
Yeah.
Thank you again for the great talk. I think in your last slide, or one of your last slides, you were talking about using big data and machine learning. Of course, the new thing is AI. So I'm kind of curious how, experts like you, how you're kind of thinking about using AI in the future.
I think AI can change the world. So one research we have done, the diabetic retinopathy, that is the retina, people get blind, and only a trained ophthalmologist can diagnose that. And in Bangladesh, not everybody can go to Dhaka, the capital, and then you pay like $20 fee. So that what we did, but you can have a now handheld machine that you can take the retinal image. So what we did that in the secondary healthcare, there is a computer and there's a doctor, not a specialist. So we took the retinal image and then AI read them. They categorized them. Before that, we created the program, not me, it's the Samsung and others. What they did, we have around 5,000 retinal image because I did a national survey for one of my research, and they created the AI. So those retinal image was diagnosed by ophthalmologists, so severe, moderate, normal, and they created the AI based on that and see that AI can recognize that severe, moderate, and normal. So what we did that at the district hospital, that you can use the AI, and then you can refer, because now many patients are going to the capital. So that I do think AI can change a lot of things, especially at the primary healthcare level. A lot of diagnosis we can do, which is not, they don't have to go to the specialist. For big data, because always we are dependent on the research data, but how large survey you can do? I did the Bangladesh National Survey. Our last survey I've done on NCD, it was 30,000 population, the whole country. But if you think of the routine data, hospital data, then you can use that data, analyze, but it's not possible for that's the machine, the learning. But there's a lot of a problem with the machine learning, that data, the quality of the data. So like in my global health course in Rhode Island, there are two clinicians, they're the emergency medical officer. And so one doctor said that, I'm talking about the cause of death, that in low-income country, we don't have the cause of death, we do the verbal autopsy. So we go to the community and ask the person, what was the symptom? And based on that, we write the symptom and doctor categorize. And he was telling me that even in the Rhode Island hospital, he says sometimes we don't have the time to write the cause of death because of the patient and the symptoms can be complicated. So so there are a lot of criticism about the routine data. Doctors don't like to do the paperwork. But if we start analyzing that, I do think that there will be more focus on how to improve the quality of the data. And if you have a data for 100,000 people, even the quality is poor, that you do a lot of data analysis, they do figure out what's happening. Yeah. But the AI is the new, in the global health, I do think that AI.
All right, and with that concludes tonight's program. Please join me in thanking Dr. Sarker.
Well, thank you very much. So the students, I will do some little bit of marketing. So the students who are interested in global health, apply to Brown. Yeah. For MPH. So there's no conflict of interest with Dickinson. Dickinson does not offer a master's in public. So, thank you. Thank you very much.